thank the Telangana CSI and Dr. Kasturi for giving me this wonderful opportunity to speak on the current status of interventional cardiology in this part of the world. Just touch upon the three areas like the past, the present, and the future, because to know where do we stand, we need to look at what is behind us and probably have to sneak at what is ahead of us. So what is pediatric cardiology? Like when I started DM, pediatric cardiology was just in its initial era, like around early 2000. It's a specialty that deals with congenital heart disease at any age and probably in acquired heart defects in the pediatric age group. It's a very small specialty. Since I've written it in a small, it includes only a small area. Predominantly is congenital heart disease and structural. It's known as a separate entity in the 90s and 1940s to 50s in the world, basically in the West. And then in India, it came to as a separate branch in 80s and 90s, thanks to Dr. Rajendra Tendon and Dr. Parvati Srivastava, who did create a lot of work to bring it into the main forum. And then comes the interventional pediatric cardiology. It took even longer, probably towards the late 90s and early 2000, it was probably considered as a separate entity, basically with the advent of devices. So when you look at the development of pediatric cardiology, its timeline is around 40s, 60s, you have the concepts coming in. In 1970s, with the availability of open heart surgery and the 2D echo, the B mode came in. And 80s, the start of cardiac interventions. And 90s, late 90s, probably the neonatal interventions. And in the present decade, earlier decade, probably you have the hybrids and the pulmonary wall placements and prenatal diagnosis and fetal interventions coming in. So just have a quick look at the past. As the morning, Dr. Dayasagar has said, it's 1929, it's Frostman who started off all this when he put in his urinary catheter and walked to the cath lab, in the radiology lab, and then did his own angiogram. Then there's an X-ray to confirm, no, sorry, not an angio, did only get X-ray only at that point of time because there is no CNE available. So the X-ray showed that the catheter inside the heart. Again, it's a start of both of cardiology and pediatric cardiology. But when it comes to concepts of pediatric cardiology, how to go ahead to intervene, this is Helen Taussig from Johns Hopkins, she was a person who started the clinical cardiology and thought of intervening in pediatric cardiology, basically surgical. And coming to the father of pediatric cardiology interventions, it is William Rashkin. It's in the 60s, he thought of this great idea about almost all the newborns and the infants were dying of the TGA transposition, as you all know. And he thought of this idea of making a bigger hole in the atrium to have a better mixing, so that, as you all know, you have there's a Rashkin's catheter, you make a hole in the atria, which causes a better mixing, and resulted in many of them surviving to a longer age group, so that they could be operated at a later stage. So this was initially lauded by few, but then he got into trouble because of this, because it was looking at very grotesque. When you look at it, it is around 50 years back, somebody think of tearing away the atrial septum. But this is the start of pediatric cardiology interventions. So looking at purely on interventional side, it is again in 1960s, the Rashkin's balloon came in. And then it took another decade or so, the first time to develop an atrial septal device by King and Mills, which we never got an FDA approval. They did in 3 cases. They succeeded in 2 in the first case report is published. But it took another 2 or more than 1 to 2 decades to develop a proper ASD device which can be routinely used. Then came in 80s the use of balloon catheters for dilatation of aortic wall or pulmonary wall. Pulmonary wall came better. Then came in 90s or late 90s when obviously the ASD device which came to be routinely used came in the device by Kurt Amplatz. Until then, pediatric cardiology was never taken seriously. Then came the 2000, the fetal programs, the hybrids, percutaneous pulmonary wall. Majority of the interventions usually followed the adult interventions because we usually don't have a standing on our own till a few years back. Just to contradict, previous speaker spoke about like Krieger did the pulmonary wall, like aortic wall, but probably the pediatric cardiologist Bonhoeffer did a year or 2 earlier, I think in 2000 if I'm right, did the first pulmonary wall, then Krieger went on to do the aortic wall 2 years later if I remember right. So the first time probably an adult pediatric cardiologist went ahead of the adult cardiologist. In all other phases, it's usually lags behind. What are the current interventions being done for the current status for the juniors? Its majority is again is ASD and PDA or a VSD. So almost 90%, probably for 95% of interventions probably done at present, it include in the first either ASD, VSD or a PDA, and a few coarctations. Less common interventions probably can be easily done. One of the first to be done in India is a balloon pulmonary valvotomy by Dr. Savitri Srivastava in long back in early 80s. But after that, other than that, was a few numbers. That's balloon aortic valvotomy or balloon pulmonary valvotomy and aortic. Then you have few balloon atrial septostomies and pulmonary artery stentings. Then come the newer interventions like a PDA stentings, hybrid interventions, pulmonary valve comes a very narrow, small percentage, less than 1% probably. So when it comes to then the ASD, we'll just go to the ASD. This is Kurt Amplatz, the person who developed the atrial septal device. It was almost a year and more than 20 years where the first ASD device was implanted by King and Mills. But then this took this radiologist working with his son, he was also a physician, in his lab to devise this Amplatz device, which is now the standard for almost all devices. Atrial septal defect is one of the easiest one to be closed in the surgically, and then that's only one which can be done easily as of now in the cath lab. Almost 80% can be dealt with in the cath lab, probably 90%. It depends upon the anatomy of the defect, the patient characteristics, quality of the imaging, and the operator skill. This involves any intervention for that matter, especially in pediatric cardiology, because the anatomy of the defect is most important. It varies a lot. It has a great variation, unlike the coronary stuff. And then the patient characteristics varies. It could be a newborn to a 80-year-old guy. So it varies quite significantly. Your hardware all varies according to the size of the patient. And quality of the imaging, again, very exceptional is required. Unlike you don't based on angiogram, it's based on echocardiogram. So if it's a younger, smaller kid, you can do by a regular echocardiogram. But it's an adult patient, you may have to get a transesophageal echo or an ICE to get a better image. And then there's an operator skill, obviously happens. There's a regular TE which of a transesophageal echocardiogram of an ASD which can be easily dealt with in the cath lab. You have a deficient aortic rim. Other than that, it's a very clean stuff. As a three-dimensional echocardiogram, which not regularly add much to the interventionalist other than to demonstrate it better, because the discretion at which that level of clarity which given by a 2D is not yet received in the 3D, but in future it may be the future. These are the devices which first came into the work, the King and the Mills device, which first one, which are the few stainless steel rods wrapped on a nitinol, on a PTFE, and then on either sides. But none of these devices never got an FDA approval. There's a lock clamshell, the Jim lock device, this one, but none of them were routinely used now. This is a routinely used device. As you all know, this is made of nitinol. It is around 45% nickel and 55% titanium, which has a memory, which is made of wires, which made into a central waist and either size retention skirts available. And it ranges from 4 to 40, but many other companies makes bigger ones. These are the FDA approved devices which is available as of now. Again, it's majority of them are copying of the standard Amplatz device. The Occlutech device is available. You have Sera, like the LifeTech device, and the NIT occluder is also available. But again, majority of these are Amplatz which is used all over the world. Just a timeline of the same thing, which is the first one in 1975 came in, then the first device. But it took to the late 90s to develop a reasonably usefully device which can be used easily. So these are a few 3D echopictograms of an intracardiac procedure of being done. This is one of the few papers which we have published long back in 2003, which on the large devices, and 2009 on deficient rims. Now we have with the live LA appendage devices, those patients who are elderly with the atrial fibrillation chronic, we can go ahead and close the LA appendage to prevent clotting, and then probably can finish off the device also, so that there is more complete cure. We can't say cure, but at least a more easier treatment. We can avoid the anticoagulation after 6 months. The newer developments in the ASD device is again obviously the most wanted one is the bioabsorbable devices, which are being tested. Animal experiments are over. Maybe in another few years' time it will be available commercially, which are basically magnesium-based devices, which still not available commercially, so we're not going into any details of that. But what are situations when we are not going to use a device? Probably this slide, I think I made long back another. This is a primum ASD, sinus venous ASD, a large secondum ASD with absent margins, and large secondum ASDs in those small kids. Except for the primum ASD, almost all the other things can be tackled, provided you are very sub-selective and very careful in selecting the patients. Because I have done a 46 mm device around 8-10 years back, but you have to be very careful for a 41 mm defect in a sick adult patient. You have done a lot of small patients. The youngest one done as 4-month-old, which is coming with refractory heart failure. So it can be, all the rules can be closed. Even a sinus venous ASD can be tackled probably. We'll just give an example here when we are here. This is a balloon occlusion of this SVC to make sure the pulmonary vein is flowing well. SVC to make sure that there is a pulmonary vein is not obstructed, so that occlusion of the SVC doesn't give trouble. So this is a balloon occlusion of the SVC, and make sure the right upper pulmonary vein is not occluded. And then this is, once it is confirmed, then you go ahead and you can use this is a 7.5 centimeter CP stent, which has been deployed on a 1224 bib balloon. Then you can see it is deployed. You can see the unobstructed SVC flows, and probably you can see here it's working. Hopefully, yeah. This is an SVC, the 90-degree view in which you can see the unobstructed SVC flows, and there's no residual ASD flows, and you can see the pulmonary vein entering the LA unobstructed. So innovatively, we can do almost all ASDs now at present, but we may planning to have a de novo stent made similarly for a custom made for this. It's being developed. So the concerns are, now ASDs have been routinely done. A few things you have to be careful when you blindly close all the holes. One is pulmonary edema, arrhythmias, and erosions. Pulmonary edema, which is a thing which can be easily prevented, especially when you do an adult with a coronary artery disease or diastolic dysfunction. Do always check the PA pressures and the LVDP before closing it. Otherwise, you may get into trouble like this. Another dreaded complication of an ASD is an erosion. Its risk is around 0.04 to 0.3%. This is a study which came in last year, I think, which looked at all the erosions which happened from 2002 to 2014, almost 12 years. The majority are ambulatory because better documented in the West, which showed around 125 erosions in that 12-year period, of which majority occurred within the 14 days. The median period was 14 days, but 16 patients developed erosions after 1 year and 6 patients after 5 years. So you need to be careful. You can't just close an ASD and just forget it. You have to regularly follow them up. So the risk factors were not sure. The basic thing which was common in all the cases were absent aortic rim. And then if you larger the device, probably the higher the chance of getting into a trouble. There's one theory noticed in one of those papers came in a year or 2 years back, in which they said a malaligned atrial septum could be a possible theory. If you draw a diagram from the posterior rim to the anterior rim of the defect, it should cut in the center. Normally, it should cut the sinus in the center. But then the device should be staying like in the left upper one. But if you have a defect which is slightly malaligned, you see like this here, it is when you make an imaginary line, it cuts it a bit marginally askew, like to the left of it or right of it. Then you're likely to impinge, the device is going to impinge, and then probably you may end up having erosion. This is not proven, it's one of the major postulates said, but it's going to be pretty difficult to prove it in the lab in each and every case. So let's just step on to a few more slides on PD and a few more interventions. PD, as you all know, it's quite easily done. It is an angiographic base, and outside the heart, it's quite almost 99% of the PDAs can be tackled in the cath lab. The current indications for surgeries include very low, very small patients, very large PDAs. Otherwise, almost all can be tackled in the cath lab. These are basic pictures and corroborative of the angiogram. You see in the echocardiogram and the angio picture. It was in the early 2000s we started doing the intervention. Me and Dr. Krishnamurthy, we started doing as multiple coils for majority of the PDAs because the devices were exorbitantly expensive. But then this was one of the angiograms done long back in which you can see a large PDA is seen here, and we are doing a coil closure here. But this tended to have a larger incidence of complications, around more than 5 to 10%, and then it required a longer learning curve to master this technique. So I think now I think nobody is doing a coils now except for very small PDAs, and devices have become more easy and quick to learn and do it. This is one of the few cases we did in long back in which there was a 970 gram patient kit which was requiring ventilatory support. Went ahead and did a coil with 2 coils, tied together and patient could be discharged. So it's one of the smallest kit which has been coiled at that point in the world. So with devices available now, I don't think nobody need to think about coil. It's quite easier and to master this technique of PDA coil closure, device closure. A few words on the VSD device, the next most common procedure being done in the cath lab. Now, one of the major concerns of VSD is what we can tackle in the cath lab are small to moderate size defects in the older kit, and that is not exactly what we need from as a pediatric cardiologist. Majority of the VSDs which require closure are large ones. They are in heart failure. They need treatment during the infancy itself. So as of now, we don't have a good method of closing these defects in the cath lab, but probably in the future we'll reach that. Even those ones which we close in the lab, slightly older ones and the smaller ones, there are concerns. Majority, the main concern is heart block. So in 2015, I think 3 or 4 years back, this European registry, this 2007, came up with this number, around 5% was the average heart block after VSD device closure. But after this, there have been reports which far lesser heart blocks with 1 to 2%. Obviously, we all know because the conduction tissue here is going to compress upon it, and then obviously the pressure may result in damage to the conduction tissue. This was a major device which resulted in this problem, the asymmetric VSD device, which first device with the amplifier, in which we thought was going to be useful for the perimembranous defects, which can be closed without damaging the aortic wall. But this caused maximum trouble. So nowadays, nobody uses these devices. Most often a muscular device or ADO2 is used, which is having a far lesser degree of heart block. Just coming to one of the last major intervention is a coarctation, which is again beyond 1 or 2 to 3 years of age can be tackled in the cath lab. Probably the interventional method is better than the surgery. Here you get the extremes. We can show you one example. It's almost near interruption. We'll puncture with this case which was poked through with a stiff end of a coronary wire, and then you're putting in a covered stent with a complete abolition of the gradients. And in the other extreme, you have a newborn, which usually don't go for a cath lab, but is a newborn in which severe ventricular dysfunction, there's a delay in diagnosis, came to the hospital in a severe shock and a pH of 6.9. You take him to the cath lab through an axillary route, and then you show the severe coarctation. There's an injection here which shows a tight coarctation, and you can do a stenting. Probably this was a coronary stent, some 410 coronaries and 412, in which you got a good result, and then electively can go for a surgical repair. But here I've been talking about the achievements, but there are a lot of limitations and challenges remaining. Again, pediatric cardiology interventions are quite few in number, unlike the morning the discussion going on, the huge numbers. The long learning curve with the limited centers requires a big team to support you. You need a surgical team, you need an ICU, you need a pediatric cardiac intensivist or an anesthetist. The economics are not favoring the pediatric cardiologist. Device designs which are required for a smaller infants and for a somatic growth is not yet to be designed. Majority you can use for the older kids. You have interventions which can tackle only 20-30% of the pediatric cardiac problems. You have a large percentage still requiring surgery. And we continue to remain as a parasite to the adult program. Otherwise, survival as a whole is still difficult in India. Challenges continue. We don't have a good data collection systems for our complications. There's yet to have a good registry, so we can't look back at our own results. The follow-ups in many parts of our country is hardly few. There are a few areas in which the support from the government programs so that straightforward regions are targeted because the money is fixed, so you don't do difficult cases. Complex cases are avoided. Those actually require life-saving procedures are avoided, and simple, straightforward lesions are tackled easily. Again, there are no takers for complex procedures. And there are other areas in which legislation is required for who and where the pediatric intervention should be done, whether there are no guidelines on what is the competence and who should be given the privileges to do a pediatric cardiac interventions. They may have to invest as a future to more in the research and development, should involve the industry and the academia in developing ingenious devices, and more clarity is needed in the training and privileging of interventionists. Probably, I'm not going to the future interventions for a short of time, just will quickly go through. These are the areas which are coming up. You're all already there. Pulmonary artery, banting, transcutaneous, transcatheter, pulmonary valve implantation, hybrid procedures, fetal interventions. I think tomorrow Dr. Nageswara is going into details of these advances. These are the Melody valve, which I said came up first in 2000. This is the one valve which I did in around 3 years back, the venous valve, which was done in a center, in which we could implant a venous valve here. This is a percutaneous pulmonary venous valve, which is a self-expanding one. This is one of the fetal interventions, hybrid intervention, not fetal, hybrid intervention for hyperplastic left heart syndrome. Fetal interventions are nowadays done for balloon aortic valvotomy predominantly. To conclude, the pediatric cardiac interventions have come a long way, and then they made great strides. Majority of them are done as ASD, VSD, coact, as I said. Further development research needed before we can tackle more lesions in the cath lab. Great challenges remain and need concerted collaborative approach from the physicians, industry, academia, and regulatory bodies for greater innovations. Thank you.